Hi, I'm Preeti. I know there was some question about what a hospitalist is. Medicine is so different now, so you can choose to do either private practice or work in a hospital setting. So I am fortunate to work in a hospital setting and not have to do private practice anymore. And you just do shift work, covering all the OBGYN patients in the hospital during either a 24-hour or 48-hour period. So that's what I do now. So to get started, I kind of put together a small talk with an introduction with some of the important topics in women's health. Preventative care is such a large topic, whether it's men's health or women's health. So this is just a portion of it. If you can advance to the first slide, please. So basically, to start, preventative care is an important topic in all of medicine. It basically helps catch illnesses at early stages to help prevent long-term complications. Cervical cancer screening particularly is important in women's health. So the cause of cervical cancer is the HPV virus, which is a virus that causes an HPV infection by entering cells and causing changes to those cells and ultimately leading to cancer of the cervix, vagina, vulva, or anus. There's about more than 200 subtypes with about 40 subtypes that affect the female genital area. It's contracted via skin-to-skin contact. Most people's immune system can clear the body of this infection before it does cause diseases, but for some patients, it can cause genital warts and cervical cancer. Therefore, cervical cancer screening is very important. Some of the risk factors for cervical cancer include cigarette smoking, immunocompromised patients, HIV, and sexual intercourse. And some of the signs and symptoms to watch out for cervical cancer are vaginal bleeding, foul vaginal odor, and pelvic pain. So screening for cervical cancer typically begins at the age of 21. And basically at 21 to 29 years old, it's recommended that you obtain a pap smear every 3 years. And between the ages of 30 and 65 years old, they recommend a pap smear every 3 years, or something called co-testing, where they test for the pap smear and HPV every 5 years. Now, for patients who are over 65, the decision whether or not to continue pap smears depends on their medical history. So anybody who has a history of abnormal pap smears, it's recommended that they continue their pap smears. However, if they do not have a history of abnormal pap smears and they're not immunocompromised, then if they've had 3 negative pap smears in a row, or 2 negative co-testings in a row within a 10-year period, with the last test in the most recent 5 years, then you can discontinue this. Now, just because we say you can discontinue it doesn't mean that you should stop going for your yearly checkups to the OBGYN every year. Pap smear is just one form of diagnosing issues that can occur for women. So it's still recommended that you go yearly for your pelvic exam and breast exam to your OBGYN. And if for patients who've had hysterectomies, the guidelines are pretty similar to those that are 65 and older. It depends on your medical history and if you have 3 negatives in a row. The next would be breast cancer screening. And with breast cancer screening, at least 1 in 8 women do develop breast cancer in the United States. Some of the signs and symptoms of breast cancer include feeling a lump or mass, any skin changes, or any nipple discharge, including bloody nipple discharge. Some of the risk factors include family history of breast cancer or ovarian cancer, BRCA1 and 2 gene mutations, a history of radiation therapy to the chest at a young age, or a history of high-risk breast biopsy results, or obesity. So typically, the way we screen for breast cancer is mammograms, and these begin at the age of 40, and we recommend yearly mammograms. Now, different societies are going to recommend different things. I'm going based on what most OBGYNs are recommending. For those who are high risk for breast cancer, especially if they have a first-degree relative that has been diagnosed with breast cancer, then their screening begins 10 years prior to their youngest relative that was diagnosed. For those who have BRCA1 and 2 mutations, they typically begin screening at 25 years old with breast MRIs and ultrasounds every year, and then at age 30 with mammograms and MRIs every year. And then they do recommend clinical breast exams every 6 months regardless. So the way to perform a breast exam is you want to do self-examination at least once a month. Pick the same time each month, and then you want to look at your breasts in the mirror with your hands at your sides and then above your head. So what you're first doing is you're going to use the pads of your fingers to feel for any unusual changes around the breast and the armpit. And then you're going to move in a circular motion from outside to inside. And you're really feeling for any sort of lumps, hardened knots, or other changes. You're also looking for signs of redness, swelling, or skin dimpling, and then changes to the nipples in appearance, texture, or if there's any discharge. Next slide, please. Osteoporosis is also an important thing, that part of preventative care. It's basically a decrease in the bone density, which can increase our risk for fractures. So some of the risk factors of osteoporosis include long-term steroid use, inflammatory bowel disease, rheumatoid arthritis, autoimmune diseases, lupus, vitamin D insufficiency, low calcium intake, excessive vitamin A, high caffeine intake, high salt intake, excessive long-term use of antacids, alcoholism, immobility, smoking, being too thin, a previous history of fractures in a parent, early menopause, and cancer, and falling. So how do we screen for this? We obtain DEXA scans starting at the age of 65 every 3 years. Those patients who have a history of a bone fracture, particularly of the back or the hips, and they have risk factors, then they may have to start their screening process earlier. So the treatment basically for osteoporosis helps prevent any future fractures. So typically you would treat with vitamin D, calcium, and medications based on the bone density scan results. So prevention, we do recommend exercising about 20-30 minutes per day. Weight-bearing exercises are while standing that requires your bones and muscles to work against gravity is what's really recommended. So these kind of things include like brisk walking, yoga, Pilates, strength training. Healthy diet with calcium-enriched foods and vitamin D-enriched foods can also help prevent this, and avoiding smoking. Next slide, please. So pregnancy is a large part of women's health. Nutrition in particular, there's a common misconception that people are eating for two, which is a very big common misconception. So basically women who only have one baby or pregnant with one baby, they only need an extra 350 calories per day in the second trimester. And for those pregnant with twins, they only need extra 600, and triplets an extra 900. We do recommend daily prenatal vitamins and folic acid supplementation. For folic acid supplementation, we do recommend this at least 1 month prior to achieving pregnancy. And you want to continue it throughout your whole pregnancy, but particularly until the first trimester is over. And then for high-risk patients, we do recommend 4 milligrams a day. And you want to start this 3 months prior to achieving pregnancy, and you want to take it for the remainder, or at least until the first trimester has been completed. Prenatal vitamins do include iron, but it is important to make sure you're getting at least 27 milligrams of iron per day, which is usually in prenatal vitamins. And then you want to make sure you do eat iron in rich foods, which include like beans and lentils, breakfast cereals, turkey, shrimp, oranges, grapefruit, strawberries, broccoli, spinach, peppers. It's important to get about 1,000 milligrams of calcium per day. And then obviously eat calcium-rich foods. Same with vitamin D, it's important to get about 600 international units per day. And again, vitamin D enriched foods. For weight gain and pregnancy, it's important to remember that it's for patients who are underweight or normal weight, they only need to gain 25 to 35 pounds. And those that are overweight and obese, it's recommended to only gain about 10 to 20 pounds. You do want to avoid foods that are high in carbohydrates because people do tend to develop diabetes in pregnancy. So it's important to remember to avoid some of the foods that are rich in carbohydrates. And one of the most important parts of everything in life, including pregnancy, is hydrating, and particularly with water. Next slide, please. We do recommend about 30 minutes a day of moderate intensity for exercise during pregnancy as well. And that includes anything like brisk walking, swimming, bicycling, yoga, Pilates. And those that have exercised prior to pregnancy can continue the exact same activity at the same pace. Again, hydration is key. It helps prevent a lot of issues and complications that we incur in pregnancy. You do want to avoid sleeping flat on your back, and you want to avoid sitting for long periods of time, especially on airplanes. And make sure you wear your compression stockings and move your ankles up and down to help circulate your blood. Next slide, please. Nausea and vomiting is a common problem in the first trimester. It's usually caused by an increase in acidity or acid reflux. So the way to help avoid this is to avoid foods that are high in acidity. For example, tomatoes, particularly tomato sauce from a can or a jar, cheese, spicy foods, fried foods, fast foods, potato chips, chocolate, sodas. So what can you do for the nausea, vomiting, and pregnancy in first trimester particularly? Take Tums or calcium carbonate chews. We do recommend smaller, more frequent meals and eating an early dinner. You can also take acid reflux medicine, for example, like something over the counter like Pepcid, 40 milligrams a day. And the way to take that would be to take it first thing in the morning on an empty stomach before you eat or drink anything. Wait a good hour and then only try to eat or drink something. Try to eat a bland diet, like a brat diet, which includes bananas, rice, applesauce, toast, crackers, oatmeals, mashed potatoes, sweet potatoes, things like that. Ginger tea, ginger ale, and ginger candy do help some people. And again, hydration is key. You can, even if you don't eat for the entire first trimester, as long as you're hydrating, your baby will be fine. Next slide, please. So early pregnancy loss does affect about 10% of pregnancies. The risk of early pregnancy loss increases as a woman's age increases. So for women who are greater than 40 years old, about 1 in 3 pregnancies end in a miscarriage. Early pregnancy loss is considered any loss before 13 weeks, and it's usually caused by the embryo not developing properly due to an abnormal number of chromosomes. So it's usually a random event, and it was going to happen regardless of what anybody did, unfortunately. Some of the signs and symptoms include bleeding, gushing of fluid, or passage of tissues. For those that have had more than two or more miscarriages, we do recommend seeking ObGyn consultation for further testing to see if there's any underlying causes that are leading to this. And then for those that do have a miscarriage, one of the common questions is, how long do you wait until you get pregnant again? And the answer to that is you want to wait at least 2 weeks after a miscarriage to try to get pregnant again. And you want to be cleared by your provider as well. Next slide, please. Unfortunately, age is a factor in fertility, and chromosomal abnormalities do increase as the woman's age increases. So for example, for women who are 30 years old, there's a 1 in 940 chance versus a woman who's 45 years old, there's a 1 in 35 chance. So when do you consider an infertility evaluation? For any female who's over the age of 35 and has been trying to conceive for about 6 months and has been unsuccessful, we recommend fertility evaluation. And for any woman who's over the age of 40 prior to trying to get pregnant, recommend a fertility evaluation. Next slide, please. Depression is a very particularly postpartum depression is a very common problem in pregnancy. It affects about 1 in 10 women. And some of the signs and symptoms to watch out for would be depressed mood most of the day, nearly every day, loss of interest, feeling guilty or hopeless, sleeping more than normal or having trouble sleeping, loss of appetite, weight loss, eating more than normal and gaining weight, lack of energy, trouble with concentration or completing tasks, or making decisions, being restless or slowed down, or suicidal thoughts. A patient who has a history of depression can also have an increased risk of postpartum depression. And postpartum depression is very common and it's very normal. Therefore, it's so very important to seek medical advice for treatment and to let your ObGyn provider know that you are feeling the above symptoms, and it's better to let them know sooner than later. Next slide, please. Some of the common medical conditions that you can encounter during pregnancy stem from hypertension, obesity, and diabetes. Hypertension in particular includes either pre-existing hypertension or hypertension during pregnancy, or complications from hypertension, including preeclampsia and HELLP syndrome. Some of the risk factors include pre-existing high blood pressure, pregnancy with more than one fetus, history of kidney disease, history of diabetes, any autoimmune illness like lupus, obesity, age greater than 35, a pregnancy achieved with IVF, race, lower socioeconomic status, or complications in previous pregnancies. Obesity as well is a common American problem and a common problem that we encounter during pregnancy as well. This can lead to, same thing, hypertension, preeclampsia, diabetes, sleep apnea. And diabetes, patient can either have pre-existing diabetes or gestational, which means that you became a diabetic during your pregnancy, which is typically tested for at 28 weeks or earlier if you have risk factors. So this is caused by pregnancy hormones that interfere with insulin production and cause a spike in your blood sugar. So some of the risk factors for this are obesity, previous history of gestational diabetes in a previous pregnancy, previous large baby in a previous pregnancy, high blood pressure, heart disease, family history of diabetes, etc. This typically does resolve after the birth of the infant. However, it is highly recommended that patients who are diagnosed with gestational diabetes get tested at their 6-week postpartum visit for their risk of developing overt diabetes in the future, because they are at increased risk for developing diabetes in the future. So whether you have diabetes, high blood pressure, obesity, all of these can increase your risk for birth defects, low birth weight, high birth weight, decreased blood flow to the placenta, labor difficulties, increased risk for C-sections, bleeding after delivery, vaginal tears, jaundice in a newborn, birth trauma, premature delivery, underdeveloped lungs in the baby, blood sugar problems in the baby after delivery, and increased amount of amniotic fluid and stillbirth. Next slide, please. So a major topic in women's health always stems from menstrual cycles. So during normal menstrual cycle, your levels of hormones, which are your menstrual cycle is controlled by estrogen and progesterone, they increase and decrease in a regular pattern. Ovulation occurs in the middle of the cycle, and menstruation usually occurs about 2 weeks later. So your normal menstrual cycle length is between 24 and 38 days, and normally typically lasts up to about 8 to 10 days. And changes in the menstrual cycle can occur in different phases of life, like perimenopause and menopause. So perimenopause, what is that? It's basically years leading up to menopause is what we call perimenopause. So this can last for up to 10 years. So during perimenopause, there are shifts in hormone levels, which can affect ovulation and cause changes in your menstrual cycle. So this can lead to either irregular spotting or bleeding, changes in your length of your periods, changes in the number of days between your periods may increase or decrease. Some months of your period may be longer and heavier, while other may be shorter or lighter, and you may begin to skip periods. Next slide, please. There, perfect. So menopause is the time in your life when you're naturally stopped having your periods. So this basically happens when your ovaries stop making estrogen, and that helps control your menstrual cycle. So it marks the end of your reproductive year. So basically, no periods for 1 year means you are menopausal. The average age of menopause is 51 years old, but the normal range is anywhere from 45 to 55. So common symptoms and changes that occur during menopause are hot flashes. So that's typically where you have a sudden feeling of heat that rushes to the upper body and face. It may last from a few seconds to several minutes, and it may occur a few times a month, several times a day, or throughout the night. You can also get sleep disturbances, where you either have trouble sleeping, trouble falling asleep, or waking up too early, or you can have night sweats that may also disrupt your sleep. Vaginal atrophy is also a common change that can occur during menopause, and it's from the decrease in levels of estrogen that cause the lining of the vagina to become thinner, drier, and less elastic. And that causes quite a bit of discomfort during sexual intercourse and increases the risk of vaginal infections and urinary tract infections. And you can also experience bone loss, as we were talking about earlier, which can also occur with menopause. There is a small amount of bone loss that occurs after the age of 35 for men and women. However, during the first 4 to 8 years after menopause, women lose bone more rapidly due to decreasing levels of estrogen. Too much bone loss can then increase your risk for osteoporosis, which can increase your risk for major fractures. So the bones that are affected the most are going to be your hip, your wrist, and your spine. Next slide, please. So menstrual cycle irregularities can cause abnormal uterine bleeding, which can occur at any age. So common times to experience irregular menstrual cycles are when a girl first starts having their periods between 9 and 14 years old, or beginning in the mid-40s when women start experiencing symptoms of perimenopause. Again, that's the years leading up to menopause, and it may cycles may become irregular with the days between periods changing or skipping periods, or the bleeding could get heavier or lighter. So what's considered abnormal? So abnormal is basically if you're bleeding or spotting between your periods, if you're bleeding or spotting after sex, if you have heavy bleeding during your periods, if you're bleeding in between your menstrual cycles, if your menstrual cycles are more than 38 days or shorter than 24 days, or if your cycle length varies between more than 7 to 9 days. And any bleeding or spotting after menopause is not normal. Next slide, please. So some of the causes of abnormal bleeding could be problems with ovulation, and that could be hormonal irregularities. Could be fibroids, and fibroids are basically benign tumors that arise from the different layers of the uterus, and they can cause irregular and heavy menstrual periods or painful menstrual periods. You could get polyps, which are basically non-cancerous growths that develop from the lining of the uterus called the endometrium. That's the lining that we shed every month when we have a cycle. They can either attach to the wall of the uterus or the lining, and they can cause irregular heavy bleeding. They can sometimes grow in the cervix and cause bleeding after sex as well. Adenomyosis is basically a condition where your glands of the uterus, from the inside lining, they grow into the wall of the uterus and can cause painful cycles. Bleeding disorders can also cause abnormal bleeding. Some contraceptive methods can also cause abnormal bleeding, and their treatment with contraceptive methods needs to be tailored individually based on the cause of the bleeding. Miscarriages or ectopic pregnancies can also cause abnormal bleeding. Ectopic pregnancies are basically abnormal pregnancies that are not viable, that are implanted outside the uterus. Endometrial atrophy, which is basically saying that the lining of your uterus has thinned out because of the lack of estrogen after menopause, and because it becomes so thin, it can cause bleeding. On the other side, endometrial hyperplasia is where the lining of the uterus is too thick. This is commonly found in obese patients, and it's often caused by excess of estrogen, causing the lining to become very thickened and then eventually leading to irregular heavy bleeding. In some cases, this lining can become so thickened that the cells can become abnormal, and it can lead to an increased risk of cancer of the uterus, or what we call endometrial hyperplasia. And then uterine cancer and cervical cancer is also a cause of abnormal bleeding. Next slide, please. So fibroids are one of the causes I was talking about that can cause abnormal bleeding, and they're benign growths that develop from the muscle tissue of the uterus. So in this picture, it shows that there's different kinds of fibroids you can get. So you can get one that's from the inside lining of the uterus, where we have our periods from. You can get some that are in the muscle layer of the uterus, or you can get some from the outer layer of the uterus, or you have some that implant on the outside of the uterus and are just attached by a stalk. So the size, shape, and location can vary, and your symptoms vary based on the size, shape, and location. So you can have one, or you can have multiple of different sizes. And they can be associated with cancer, and they may remain small for a long period of time, and then they suddenly grow rapidly, or they can grow slowly over a number of years. And typically, for most patients who have not had issues with them after menopause, because of the lack of hormones, they actually decrease in size. So who's most likely to have fibroids? The most common people to incur fibroids are going to be women in the age group of 30 to 40, particularly 40 years old. They can really occur at any age, and they occur more often in African American and Asian and Hispanic women than Caucasian women. And they typically occur at a younger age and grow more rapidly in African-American women. Next slide, please. So what are some of the symptoms that you'll experience or that are associated with uterine fibroids? So you're going to see change in your menstrual cycle. So either they'll become longer, more frequent, or heavier, or sometimes you bleed between your cycles. You can have severe pain during your cycles. And because of all the blood loss, patients become anemic, where their blood counts decrease. And they feel fatigued and tired. Again, pain is a common symptom, and depending on, again, the location and size of it, you can either have dull, heavy, aching pain. Sometimes it can be sharp. Sometimes there could be pain during intercourse. Some fibroids grow rapidly, or if they start to break down, and those fibroids are going to actually cause significant pain as well. The fibroids that are attached by a little stem on the outside of the uterus can sometimes cause pain, nausea, and fever. Depending again on the size and the location, it can cause pressure just like a baby does. And so you can have difficulty urinating or frequent urinating or constipation, rectal pain, difficult bowel movements, or abdominal cramps. You can also get abdominal swelling as the fibroids increase in size and the uterus increases in size. You'll get abdominal swelling, and some women can even have uteruses as large as the pregnancy with fibroids. Some of the miscarriages can also be caused by fibroids, and that's typically if the fibroids are the inner lining of the uterus. So if women have, that's why if women have more than 2 miscarriages, 2 or more, we recommend infertility evaluations, because you want to make sure that that's not what the cause is. And then some women are completely asymptomatic and have no signs or symptoms of uterine fibroids, and they're found incidentally. Next slide, please. The diagnosis of abnormal uterine bleeding. So typically you start out with a history, and particularly menstrual cycle history. So you want to give a detailed history of the dates of your cycles, the date starts, date ends, how long it is, and what type of bleeding you're experiencing on each day. Physical exam is obviously a key factor for us, and then blood tests where you look at your blood counts to see if you're anemic, and your hormone profiles to see if it could be a hormonal imbalance issue. Pregnancy test could be cause of abnormal bleeding, so that's why that is also done. Any pap smears or sexually transmitted disease testing can also be done for those that have abnormal bleeding. And then further testing may also be needed, and it could be based on the age and symptoms of the patient. So anything from what we do an ultrasound, where we look at the size, location, and the amount of fibroids, versus a biopsy or surgery or MRIs or CTs. Next slide, please. So how do you manage this? So typically it depends on the cause. So because there's so many different causes, and for this, your treatment is really based on that. So some people can take contraceptive methods to help for cases of heavy bleeding, hormonal irregularities, fibroids, or thickening of the lining of the uterus, which we call endometrial hyperplasia. And those contraceptive methods can actually help regulate menstrual cycles. So typically that would mean like anything like pills or patches or rings, or what we call an IUD, which is an intrauterine device, which can be placed inside the uterus by your provider to help reduce the bleeding that you experience with fibroids. GnRH agonists, these are medications that basically stop your hormones at the level of the brain. And it's basically given to shut off menstrual cycle to stop bleeding, so that it can hopefully possibly reduce the size of fibroids, especially for those that you're worried about taking to surgery. These are used for a short period of time, for about 6 months or less than 6 months, because of their side effects. Tranexamic acid is used as well to treat heavy bleeding in some cases that are refractory to these other treatments. And NSAIDs like your ibuprofen and your Motrin, your Proxens, are going to help relieve your menstrual cramps from your fibroids and your abnormal bleeding. Next slide, please. So, some women may have completely asymptomatic or small fibroids, whether they are nearing menopause, after menopause, or even before menopause, and those do not require any treatment. No surgery, no treatment required for those. In cases where the fibroids are causing heavy or painful periods that lead to anemia or disrupting a woman's normal daily activities, or she's having bleeding between periods, or there's uncertainty whether the growths that they're seeing are fibroids or whether it's a mass from the ovary or it could be a potential tumor, or if there's a rapid increase in the growth of the fibroid in a short period of time, or for those that have infertility associated with fibroids or pelvic pain. For all these patients, surgical intervention may be required. So the different surgeries all depend on, again, the location and the type of bleeding issues that somebody's having. For example, the very first one listed, it says hysteroscopy and DNC. Just to give a brief explanation, it's just basically where you're taking a camera and looking inside the uterus and looking to see what looks abnormal. And if you see something, then you scrape the lining or you remove the polyp. Endometrial ablation, for example, is where you burn the inside lining of the uterus to help reduce the amount of bleeding. For those patients that do have that, pregnancy will likely not happen afterwards. So you want to make sure that you're done with your childbearing years before you actually start to do procedures like that. Uterine artery embolization is where we basically block the arteries that supply the blood vessels which are the blood vessels that supply the blood supply to the uterus, and it stops the blood flow so the fibroids won't grow. And again, that's typically done for those that we're taking the surgery so they don't bleed as much. Myomectomy is where they remove only the fibroids only and leave your uterus intact, and that's basically for those that are trying to achieve pregnancy. And hysterectomy is obviously removal of the uterus. And this is particularly done in those that have a history of thickening of lining called hyperplasia or an uterine cancer, because that would be the actual treatment for them. But it can also be done in for benign reasons, non-cancerous reasons as well. Next slide, please. So hysterectomy basically means removal of the uterus, and you can have that with or without the removal of the ovaries and the fallopian tubes. All of those factors are going to be based on age and fertility. And the type of hysterectomy that your provider performs or your surgeon performs is going to be based on the size and the location and the reason for your hysterectomy. So what happens if your ovaries are removed when you have a hysterectomy? Well, then you will go through menopause right away. You'll start to experience signs and symptoms of menopause, including hot flashes, night sweats. You may be also at increased risk for osteoporosis if it's done at an early age. And then for some patients, you can get treatment with hormone replacement therapy to relieve the signs and symptoms of menopause. And they can be directly started after surgery, but that is going to be based on somebody's medical history. Again, the different types of hysterectomy are really based on your surgeon, and it's going to be based on the size, location, and complexity of the reason why you're having a hysterectomy. Next slide, please. So again, menopause is the end of your reproductive years. So it means no period for a whole year. And again, your common changes that occur during menopause are going to be your hot flashes, sleep disturbances, thin lining of the vagina from the lack of estrogen, increased risk for infections in the vagina, and bladder because of lack of estrogen and bone loss. Now, next slide, please. So menopause is a very extensive topic, as I was talking to Dr. Ramanathan about, and the brief and the smallest or the shortest way to kind of to summarize it would be there's many ways to treat the symptoms of menopause. For example, some women are candidates for hormone replacement therapy, and that can be done through pills or patches or gels or sprays, or it can be done through vaginal creams or tablets or ring release. Now, all of these methods and all of these treatments are going to be based on someone's particular history. For example, if they have a history of cancer, history of heart attacks or strokes or blood clots, they're not candidates for hormone replacement therapy. So this is like an individualized treatment, and it's based on your personal medical history and your family history. For those that are not candidates for hormone replacement therapy, antidepressants can also be used to treat hot flashes, and this is a great alternative for those that do not want to do hormone replacement therapy. and it's at the low doses, so it doesn't affect other parts of their life. It just helps them with the night sweats and the hot flashes so they can sleep better. There are treatments like vaginal creams and tablets and rings, which basically give you localized treatment on the inside of the vagina, versus the systemic ones, which are going to be your pills, your patches and gels and sprays, which are absorbed throughout your body. So again, your treatment is going to be individualized based on somebody's personal medical history, family history, allergies, etc. So treatment's always individualized for these kinds, for menopause treatment. Next slide, please. So postmenopausal bleeding is a problem I used to see in the office all the time. It is definitely not normal, and it does require evaluation by your OBGYN. So if you have not had your period in over a year, you're menopausal. If you start to have bleeding, irregular bleeding, please seek the evaluation of an OBGYN, not your primary care doctor, but your OBGYN, to be evaluated why you are bleeding, because there are benign reasons and there are also cancerous reasons why this happens. The uterus will bleed as a sign that there's something going wrong. So it's always an alert that you should go seek your OBGYN out. So some of the things that could happen are benign reasons like polyps, which are just little growths that grow from that lining that you can remove. Again, if the lining is too thin, if the lining is too thick, cancer of the uterus, cervical cancer, hormone replacement therapy can cause irregular bleeding, any infections. Obesity is a big common factor that can cause irregular bleeding and bleeding after menopause. Any tumors of the ovaries or fallopian tubes can also cause this, and blood thinners and cancer treatment drugs like tamoxifen for short periods of time can also cause abnormal uterine bleeding. So it's really important that you seek your OBGYN out with any sort of bleeding after menopause. Next slide, please. So again, this is really emphasizing the postmenopausal bleeding because I always notice that in certain populations, we tend to go less to the doctor unless we have a major problem. When we don't want it to get to be too major, we want to catch it at the early end. The uterus will always give you a warning sign when something's going on, whether it's benign or cancerous, and it will bleed, whether it's spotting or heavy bleeding. So when the uterus gives you that warning sign, please seek out your OBGYN for evaluation to see why you're having what you're having. And it does not always mean cancer. So they will typically do a pap smear, an ultrasound. Sometimes they'll do a biopsy of the lining of the uterus. And then ultimately, depending on what's the cause of it, that would determine the treatment. So not always does it require surgery even. And some majority of the time, it's all for benign reasons. So most important take home is to seek your OBGYN out to prevent missing cancer, because the way the uterus gives you the warning signs is by bleeding. Next slide, please. So my final take home points from everything is, even though your pap smear guidelines say they do them every 3 to 5 years, depending on your provider and your insurance and your age, your insurance company and your health insurance will always cover you to get yearly exams by your OBGYN. So even if they don't do yearly pap smears, you can still go in for yearly exams. And that includes your breast exam and pelvic exam. And that's key because there's only certain things that the OB is going to pick up that the primary care doctor may or may not pick up. So that's why it's important to see an OBGYN for those. Don't forget your yearly mammograms. Don't forget your bone density scans every 3 years. And then don't forget your pap smears if you're in the age group that still needs them. And then I know I did not mention this, but this is a huge part of preventative care, is don't forget your colonoscopies. That's also very, very important. Preventative care will prevent cancer. So that's the most important take home point. For those that have young children, boys and girls can receive the HPV vaccination, which is a 3-part series, and it's starting at the age of 9. And their pediatricians can actually give this to them, and that helps prevent the development of HPV and cervical cancer. In Australia, they were able to eradicate cervical cancer because they were giving out the HPV vaccinations. So they made a huge change in their population by doing that. So that's important. Vaccinations are important. Don't ignore any irregular bleeding or bleeding after menopause, and seek a healthcare provider for any symptoms of depression. It is normal. It's a common problem, and there's multiple reasons why it happens, and does require treatment, and it's okay to do that. And pregnant patients, for them particularly, they must watch their diet and weight gain during pregnancy to prevent complications. Particularly, one thing I noticed in our population is rice and rotis and things like that. I used to see a lot of diabetes, and a lot of way I controlled it was to help them, to make them stop eating that and eat alternatives to that, like cauliflower rice or things like that. So those kind of things are very important to help prevent diabetes and high blood pressure in your pregnancies. And exercise is important for everyone, and that's the last thing. Any questions?
I have a few questions from our center.
Okay.
The first one is, dear Dr. Preeti, my pap smear tests have been normal so far. In future, if they find cancer cells in my smear, what is the treatment? That's the first question.
So the pap smears have been normal, but if they do find it in the future, if they do find it, it depends on the level of abnormality. So it depends on the final, what the actual result of the pap smear is. Typically, anytime somebody has an abnormal pap smear, they start out with taking a microscope and looking really closely at the cervix to see if we see any abnormal cells. And then if we require biopsy, then we do a biopsy, and then we scrape the inside cervical canal to make sure that it has not gone up the cervical canal to infect the uterus. So it all depends on the severity of the pap smear, whether it requires a procedure or a repeat pap smear.
Okay, the second question is, dear Dr. Preeti, I have endometriosis and severe pain during periods. I've heard that this condition can cause cancer. Is there any way to check if I have cancer and avoid cancer, or is there any way to avoid cancer? That are the two questions that I have for you. That's the second one.
So endometriosis is a very large topic as well. I know I didn't touch on it in this PowerPoint, but it can increase some people's risk. It's all individualized, but the main thing is with the treatment of those heavy and painful periods, painful periods, a lot of times the treatment is to shut off the menstrual cycle until you're ready for childbearing. And then once you're ready to conceive, and then go back on suppressive birth control to help decrease any issues from the endometriosis, because endometriosis in particular can cause infertility as well. And that's a common problem that a lot of women have. So it's important to suppress the menstrual cycle for those patients.
Sorry, you can maybe explain to the crowd what endometriosis is.
So endometriosis is basically where when we have our periods every month, the inside lining of our uterus, it builds up and then it sheds out. And what we see is our lining of the uterus shedding out each month. Endometriosis is where the glands of that lining of the uterus go and implant in different parts of your body. So they can implant in your bladder, in your intestine, along the inside of your, pelvis, anywhere, and they can cause severe pain when you're actually menstruating, because you're bleeding into those spots where those glands have implanted, and it causes severe pain and issues in those particular areas. So that's why the key to treating endometriosis is suppression of the cycle.
Oh, okay. So is there any more questions from the audience? Lakshmi, if not, I'll go on to...
Jaya, let us go ahead and finish the questions that you have, then we can open it up if time permits.
Okay. The next question is, when should a girl start self-breast exams?
Really, anytime after, you start menstruating.
And how often? How often and when?
Every month, and usually after you start menstruating, you should start. And you need to make note of the timing of the cycle if you're feeling anything abnormal.
Okay, the next question is, when should a girl, I presume it's a teenage girl, start getting pap smears?
Starting at the age of 21, but you should still go to the gynecologist once you start your cycles, because sometimes women will have issues with heavy periods or painful periods or things like that need to be addressed during those years, even if it's not, even if they're not 21.
The next question, Preeti, is when should a woman stop getting pap smears? Is there a time period?
So, so it really depends on someone's history. So if they're over the age of 65 or have had a hysterectomy, if you have no history of abnormal pap smears, and you've had 3 consecutive negative pap smears in the last 10 years, with your last pap smear being about 5 years ago, you can stop them. However, if there's any history of abnormal pap smears, then you don't necessarily stop them. So, and the frequency is going to depend on the severity of those abnormals.
And the
But
next,
even if we stop pap smears, we still don't stop doing pelvic exams and physical exams. So you should still go yearly to your OBGYN just for your physical exam.
what age should we start getting mammograms?
Ages 40, unless you have a first degree relative, meaning like, you know, your sister or mom or somebody, if they were diagnosed with breast cancer, then you would start 10 years prior to the youngest family member diagnosed. Otherwise, you would start it at 40. If you have a history of the BRCA1 and 2 mutations, you would start it at 25.
This is regarding ultrasound versus a mammogram. Can you comment on that?
It just depends on what they're looking at. If you're a younger female, they're going to want to do a breast ultrasound and an MRI because mammogram, because you will have dense breast tissue and you can get false positives that way. So ultrasounds sometimes are used for that purpose for younger individuals, and they're also used to see whether the mass or the lump or the abnormality they're seeing is if it's a cyst, meaning like fluid filled, or is it something that's more like a hard, like a solid mass, like a tumor.
And the last question on this list is, what is the best gynecological hygiene tip that you can provide us?
Meaning, like, I guess.
Not sure, but it's a question from someone.
There's nothing different that you need to do down below. Douching is not recommended. It's recommended just to use normal soap and water. A lot of people have issues with scented soaps and stuff like that. So you can use things like Dove soap, which is more sensitive to the skin. But other than that, typical normal hygiene practices are acceptable.
Okay, those are the questions I have, Akrita and Lakshmi. Do you have any more?
Yeah, there is one general question, Preeti. What are the alternate foods for individuals with diabetes? We as Asians consume a lot of rice. So the question is wheat good? Or how do we assess what is a good alternative for rice? How do we assess that?
So that's a good question. It's a common problem I had in my Asian and Indian population when they were pregnant. They all developed diabetes and they used to all be stick thin, but they were all developing gestational diabetes, and it was probably just some insulin resistant from the placenta. So alternatives can be like cauliflower rice. I know there's a lot of alternatives to rotis now with the ragi rotis and the millets and all that everybody eats. So those are good. Grains are okay, but you want to stay away from your carbohydrates, like your those are all still carbohydrates, but you want to stay away from your big culprits like your rice. Certain foods, like certain fruits, are going to be very high in sugar. Like summertime, everybody loves their watermelon and mangoes and pineapple, their green grapes. All of those are high in sugar. You know, your berries are going to be better for you, like your strawberry, raspberry, blackberry, blueberry. Your purple grapes are better than the green. Your red apples are better than green. Green have more sugar. Cantaloupe and honeydew are good for you. You want to stay away from your, again, watermelon, pineapple. I know we love mango, because those are all high in sugar. You know, you want to stay away from like your sodas. You want to stick with more water. Sodas are just garbage, is what I tell everybody. There's no like nutritional value in any soda. It's all just sugar and, you know, carbonated water and garbage. You're better off with just water. you can do a lot of these alternate. Now you can use almond flour for a lot of stuff. You can use the cashew flour. You can, it's really cutting down on those breads, the breads and the rices and the, potatoes, it's a lot of this, and adding more protein, whether it be like a protein shake, some of them like Premier Protein is a good protein shake to drink that doesn't have as many carbohydrates. It's water-based and not milk-based, and it's got a high protein content. Unfortunately, our Indian food, unless you eat meat, does not have any sort of protein content. My parents used to always tell me, oh, but lentils. More as I got older, I kept looking it up, and lentils don't have as much as what we really, really should be getting on a daily basis. So really incorporating those protein shakes is going to be key. And that will, when you eat, they always say to eat less carbohydrates and more protein, so that you metabolize better and you decrease your risk for diabetes and stuff. So egg whites are a good alternative or eggs. But for those that don't want to eat eggs, they can do egg whites. That's also a good alternative. And now they have keto breads and things like that in the grocery store. They're a little bit more expensive, but they also will help you. So those are some of the key stuff. And juices, stay away from juice. There's no nutritional value in any juice unless you're freshly squeezing it yourself. Anything that you buy in the store is all sugar. So freshly squeezed, okay. Store-bought, not okay.
Thank you, Preeti. That was wonderful. So many alternatives you've suggested. Thanks a lot.
And there is one more question I saw in the chat box. Do you see it, Lakshmi?
Also, for noodles, instead of doing pasta, you can do zucchini noodles or squash noodles and things like that. So you get your veggies in, but you're also getting, it's a lot of fiber and stuff, and it's not the pasta.
Thank you. Go ahead, Jaya. You can ask the question.
I cannot open it. Can you read it off of the chat box?
No, I think this was the only question that I see about diabetes. I don't see any other question. Anybody else is able to see some of the question?
Oh, I can see some of them.
Where do you look for zucchini noodles? That's the question.
You can actually get them at the grocery store. A lot of stores actually have them in the frozen section, although I highly recommend actually spiraling the zucchini yourself. So if you have like a KitchenAid mixer, they make the attachment, or you can even buy the little zucchini noodle thing from Walmart or something. And you basically it looks like something from India. Basically, you put the zucchini there, and then you just like turn it, and then it spirals out the zucchini.
Oh, wow.
And and then you take a little salt, and then you want to sprinkle it on your zucchini noodles, and then squeeze all the water out of the zucchini so it doesn't affect your sauces. So in the places where where they already have it available, it's easy, but otherwise you can actually spiral it out yourself, which is what I do.
Wonderful.
I have a question from the chat box. If someone has IUD, then regular periods is not there, which means we cannot check to see if the cycle is regular. How do we check the uterus health without using period cycle as a guide?
You don't need to check the health. It's totally normal. It's okay for you not to have periods if you're using an IUD. That's a very normal thing. So you don't have to do anything in particular to test the health of the uterus. The uterus is fine.
The second question here is, what are the natural ways to get estrogen in diet instead of taking medicine?
There's nothing like our natural hormones, I'll be honest. So it is natural for us to lose our hormones. So that is a natural process too. So some of that is our acceptance in losing our hormones and managing our symptoms, of menopause. But there's nothing besides actually taking the hormones. You really can't replace them in food. But not everybody's a good candidate to take the hormones either. So that's the important key factor, because it does increase your risk for strokes and blood clots and heart attacks, depending on your medical history. So not everybody is a candidate for that.
I have several more questions here. One, not sexually active, never been, HPV vaccine series completed, no menstrual symptoms, age 30, sees PCP regularly, and has breast exams and yearly physicals. Do they need to see GYN?
Not necessarily. They haven't started their periods yet, so they can stay with their primary care doctor or their pediatricians.
Okay. So the next question is, my daughter had a spinal surgery 3 years back. She has a 6-year-old son. Is it possible for her to conceive again? The surgery was for protruded bone.
I feel like there would be a little bit more history that would be needed to answer that question. So I think they would have to probably talk to their neurosurgeon to see if there was any defects from that spinal surgery and it affected her ability to be able to carry a pregnancy to term. Because conceiving wouldn't be an issue as much as carrying to term.
Preeti, there's one question. How do we help with osteoporosis?
So you want to do making sure you're doing your normal calcium and vitamin D is important, including with your supplements. And then also weight-bearing exercises. So you want to do things that are like, you're walking, brisk walking, yoga, Pilates, strength training, all of those things will help as well. So basically you're looking for exercises while standing that require your bones and muscles to work against gravity. So that's why we recommend brisk walking, yoga, Pilates, strength training, eating a healthy diet that's rich in calcium and vitamin D, like your dark leafy greens, dairy foods, salmon, milk, cereal, oranges, avoid smoking, and calcium and vitamin D supplementation.
Wanted to know if HRT is safe, and is there any alternative after complete hysterectomy?
It depends on your medical history if HRT is safe for you. So that's an individualized treatment. Someone's going to look at your family history of cancer, your personal history of cancer. Why did you have a hysterectomy? What was the reason for it? What is your medical history like? Do you have any high blood pressure or diabetes, history of strokes or blood clots, any bleeding or clotting disorders? So based on all of those factors, it's individualized to that person. Alternatives to that could be using things like antidepressants to help treat the symptoms of hot flashes, or local vaginal treatment that doesn't necessarily increase your risk for cancer, like vaginal estrogen therapy or vaginal rings that can help with the dryness down below.
Thank you so much.